Thank you very much for inviting me to speak in this conference. This is my first time in Athens. And I'm going to speak on Mitraclip for functional MR. I think my talk is over after you hear the talk just by Dr. Kisslo, and it probably tells you the difference between the Mitral France and the COAPT study. So functional MR and LV dysfunction, there's actually a relationship. If you have LV dysfunction, it leads to functional MR. And then if you have functional MR, it leads to further LV dilatation and further functional MRs. So the rationale that even though secondary MR is a ventricular disease, we feel that if you reduce MR, you might actually break this vicious cycle. And so that is the hypothesis that treating MR might make a difference. Now, what was the rationale for using Mitraclip for a functional MR? We know from surgical data that the results for surgery was actually not very great for secondary MR, and surgeons often didn't like to use this therapy for secondary MR. But the rationale for FMR comes that it helps coaptation of leaflets. I actually learned it from Maizano, actually. I thought it would work from that. It restricts annular dilatation, and it potentially helps in maintaining the LV geometry by a rain effect. This is actually a quote from his own article, with the leaflets, the clip, and the cords put together. So the point of hypothesis is that if you break this vicious cycle, you might actually adversely reduce the adverse remodeling associated with secondary MR. So the first study is the French study, which was published. There's a lot of non-randomized data, I've got to tell you, in support of use of Mitraclip in secondary MR, especially in Europe. Because in the United States, it's not approved. It wasn't approved till a few months ago. And there was evidence of safety. There was evidence of efficacy. There was evidence of actually improvement of functional class. And actually, it was very well established therapy in certain states and in certain countries in Europe. But there was no randomized trials. And so these, the first two randomized trials are the Mitral France and the COAPT. And the French was the first study, the Mitral France, which was published in ESC. And what this was, they took 452 patients with functional MR, and the way they did it is they sat in a room and they had champagne, and then they chatted, and then they said, great, put this patient in the study. They actually didn't even see the patient. They probably didn't even look at the echo, Dr. Kisslo. But anyway, they randomized 307 patients, and 152 randomized to the Mitraclip arm, 152 randomized to the medical arm, and what to me is astonishing is that after randomization, 43 patients were excluded. That means 1/3 of the patients after randomization were not to be in the study. And New England Journal of Medicine published this paper, where 30% of patients were not even randomizable. Anyway, so they left with 109 patients and 137 patients in medical arm. And this was the objective. They wanted to show that Mitraclip plus medical therapy versus medical therapy alone is better. And the primary endpoint was composite of all-cause death and rehospitalization for heart failure for 1 year. Now, what I want to show you, a big problem is what patients they took. They took patients with symptomatic. They took patients with ejection fraction of 15 to 40%, 15%, almost dead patients. They took patients with severe secondary MR, which they used the ESC criteria of ERO of greater than 0.2 or a regurgitation volume of greater than 30, which in the ASC criteria is considered to be moderate, and they were not eligible for surgery. They did not even have an upper cutoff of a ventricle size. So if you had a ventricle size of 9 centimeters, that was okay. So the only thing that you needed to be, you had to be French. And basically, the primary endpoint, when you look at all-cause mortality and unexplained rehospitalizations from heart failure, there was no difference at 1 year. Unfortunately, they did not systematically collect the quality of life data comparatively, so we don't have the data for that. If you look at this sub-analysis, the one difference was, if you look at patients with a regurgitation ERO of greater than 40 ml, which is less severe, there was actually a trend towards superiority with the Mitraclip compared to the medical arm. But the reason for that not being statistically significant is because of the wide confidence interval at a small number. But this suggested that if you treated severe MR, you might have made a difference. So what are the limitations? At 1 year, there was no difference. Small sample size, 9% of people didn't have a procedure, less severe degrees of MR. This was my interpretation. Small numbers, multiple exclusions. There was no central eligibility committee, high initial failure rate, missing data on quality of life. And I know they didn't like this, inexperienced operators, because this was the early experience in France, higher late recurrence of MR, and only 1 year follow-up. So everything changed on September 28th, 2018, when we presented the COAP trial, a trial which took 5 years to enroll and $70 million. And you can see over here, the key inclusion was a similar ischemic and non-ischemic cardiomyopathy, ejection fraction between 10 to 50%, moderate to severe or severe secondary MR confirmed by independent core lab. But I do want to draw this important example of what Dr. Kisslo mentioned, which is so good. And what he did show in those slides, he showed that there's no single criteria that defines severity. And even that one criteria that you use, color flow, has to be again qualified by the Nyquist limit. So it was very important that the core lab actually used an integrated approach to define if the patient had mild, moderate, severe. And the 6 criteria that they used is ERO, vena contracta, pulmonary vein flow, regurgitation volume, regurgitation fraction, and LA size. And that's why it was probably a little bit more accurate. Anyway, 30% of the patients which were sent to the core lab as severe were turned down by the core lab to be not severe and excluded, telling you how many mistakes we do even at qualified centers. All patients were seen at the core lab and the surgeons were there. So here is an example of a gentleman, 58 years old, with ischemic cardiomyopathy, NYHA class 3 and maximum tolerated GDMT and a CRTP with the EF of 20%, with a ventricle dimension of 6 centimeters end systolic. Patient came in and with functional MR. What would you do with this patient? Most people would agree that this is a wall-hugging jet with a large PISA, and this would be considered to be severe. The second gentleman came a few months ago. After him, 65-year-old male with ischemic cardiomyopathy, very good medical treatment, NYHA class 3, EF of 25%, regurgitation fraction of 40%, PS systolic of 42. So you have these 2 patients, almost similar, coming 2 months apart. And I didn't know what to do, but I did the right thing is I randomized both these patients in the COAP trial. I will tell you the outcomes after this. So the primary endpoints was effectiveness, all heart failure hospitalizations through 24 months. We did not expect a mortality benefit. And a safety endpoint was freedom at 12 months of device-related complications. And we had several secondary endpoints which were individually powered, most of them for superiority, but a few for non-inferiority. And ultimately we landed up with 614 patients, 302 to the medical, 312 to medical arm, 302 to the device arm, and there were only 51 cases of roll-ins. And so this was the center. Now this is another example of a problem. You can see, if you look at the number of centers enrolling patients, this were the top 10 enrolling centers, and you can see over here that 40% of the study was actually done by only 10 sites. The age was 71, which is mean. The STS score was a mixture of high-risk and low-risk patients. 30% were considered to be low-risk patients. And if you look at the ejection fraction and the severity of MR, you can see the ejection fraction, the mean was 31% plus or minus 9. So it means there were a lot of patients who were less than 30%. And 40%, as you mentioned before, 50% were 4 plus MR. And the majority of patients were, 60% were ischemic, 40% were non-ischemic. And what is most important is medical therapy. Every single patient who came for the COAP trial had to see the heart failure specialist and be treated by him for months before they actually got randomized. And you can see the medical treatment was consistent, and the medical treatment remained consistent during the 12 months with a slight increase of beta blocker use in patients who got the Mitraclip. The procedure-related complications were very low, and the MR grade achieved was very high. We could see that 95% of MR was trace MR or 1 to 2 plus at discharge. When it came to all heart failure hospitalizations in 24 months, there was 283 patients admitted with heart failure and 151 patients, which is 47%. And then you see in the medical arm, on the device arm, it was 160 admissions in 92 patients. I've read 7 of the heart failure clinical trials. I have never seen a separation of curves like this in any clinical heart failure trial. And the separations of curves took place within a month of the treatment. What it tells you, for a statistician and a mathematician and a physician, this is a great trial. But put yourself in the perspective of a patient, how much they suffered, that they suffered immediately when they got randomized, and to see the suffering that took place and separate over 2 years. So the p-value was 0.01. So actually, you require only 3 patients to actually prevent a heart failure admission over 2 years. And that is the number needed to treat to save 1 patient, just 3 patients. When it came to device-related complications, you can see that 96% of patients were free of complications from the procedure at 12 months. When it came to powered secondary endpoints, we had several powered secondary endpoints like MR grade, quality of life, 6-minute walk, ventricular diastolic diameters, all-cause mortality. We put several endpoints because we knew we would not meet many of them. But we put in several endpoints based on a hierarchical way, and this is what we achieved. I have never seen a study where 10 secondary endpoints have been met with a p-value of 0.001. When it comes to all-cause mortality, you can see that in spite of maximal treatment, 46 patients of them died at 2 years, which is almost 50% who died. When you look at the mortality on the group which read the Mitraclip, you can see that 30% died at 2 years, about 20% died at 1 year. And you can see there's absolute difference of 17%. Therefore, the number needed to save 1 life in 2 years is only 6. There's only one other study lower than that for mortality, and that is TAVR for high-risk patients, which was 5. And so you can see that if you look at all heart failure therapies, this is one of the lowest forms of patients to save 1 life, of just 6 patients to be treated with Mitraclip to save 1 life. This is another important endpoint, is the use of LVADs and heart transplants, because patients in the clinical trial were allowed to get transplants if there was needed. And you can see there was a less degree of need of transplants and heart failure in patients who got the Mitraclip. And this is important because there's a limitation on the number of transplants and LVADs that you can do. The quality of life, of course, improved very well. And you can see that there's a dramatic improvement of quality of life. And this is one aspect which was missing in the Mitrafrance study, that they actually did not systematically analyze the quality of life. When it comes to 6-minute walk, you can see there's a substantial increase in the 6-minute walk over 12 months. And then finally, NYHA class, as expected, there's an improvement of NYHA class at all time periods, 30 months, 6 months, 12 months, and actually 24 months. And if you look at MR severity, what is very impressive is that 99% of patients at 24 months had 2+ MR or less, actually less than 2+. Now, people would say that this is too good to be true because you've got such a good result. Now, part of the results, of the reason why this looks so good is because we didn't count the patients who died. So a lot of patients who died in the medical arm and the device arm could have had more severe MR when they died, and they didn't count. So that's why this result looks slightly better than what it should be. And then finally, why was there a difference between the French trial and the... So these are the fundamental differences between the 2 trials. Number one, the severity of MR which was taken in the French study was potentially less. They took larger ventricles. So they basically took patients with large ventricles and less severe degree of MR. The second important thing is guideline-directed medical treatment. In the QUAD trial, patients had to be optimized prior to randomization. And this was very important because you wanted to make both the arms equal before you randomize them. And finally, the acute results, procedural complications, and the 12-month Mitraclip results were slightly better in the QUAD trial compared to the French trial. And so cumulatively, based on these 3 issues, there were actually fundamental differences in the trial results. But I always said, the French make better wines. So you want to know the outcome of the 2 patients. So the first patient got randomized to the control arm, on medical treatment. He was only 58 years old. He had a 9-year-old child. His first time, he could remain in NYHA class 3 and 4.
3 minutes.
He got readmitted with heart failure in March, May, and September. 3 admissions in heart failure. And his referring cardiologist told me, "What are you doing with this patient? You should treat him with a Mitraclip." And I said, "The crossover is only at 24 months. He begged for the clip and was told he could cross over at 2 years. He was turned down for transplant, and he finally died on September 27, 2017. When I show this slide with emotion, it was something which I really suffered because I remember how I called his family to find out how he's doing, and nobody picked up the phone. And later his wife didn't pick up his phone. His primary cardiologist called me up and said, "He died a few weeks ago and we didn't want to call you. We were so upset." So this is what we had to face in reality. The second patient received the quart with the Mitraclip. He remained in NYHA class 2. He had no heart failure admissions over 2 years. On July 2018, he remained in NYHA 2 with mild MR, no changes in medications. So my conclusion is, this was a few papers which was actually published in New York Times. A tiny device is a huge advance in the treatment of heart failure. My therapy is in March 14, 2019, the FDA expanded the indication of Mitraclip therapy for secondary MR based on the following criteria. In patients with LV dysfunction, with the EF of greater than 20% and less than 50, with an LV end diastolic of less than 70, whose symptoms of MR persist despite medical treatment and are determined by a multidisciplinary team to be experienced in the evaluation and treatment of heart failure. And if you notice that there's no surgical risk placed to this indication. The implications are in patients with severe secondary MR with suitable anatomy, despite maximally tolerated GDMT, Mitraclip should be considered as the first-line treatment irrespective of the surgical risk. All other surgical or transcatheter valve repair and replacement options should be evaluated against the Mitraclip. Thank you very much.
Amazing study. I'm surprised that your adjudicating committee did not stop the study early, at 1 year, when the curve started to diverge. That was, I found, very courageous. And your patient example you showed would have been happier.
So I can now acknowledge certain facts. In 2016, in November, I had a significant disparity in mortality between the medical arm and the device arm. So I wrote a letter to the executive committee asking them to stop the trial. And they returned back and saying that the DSMB has not given us any indication to stop the trial. And so it was continued. So I totally agree with you. Now, if you look retrospectively, I don't understand what the DSMB was doing. The study should have been stopped.
Thank you very much, Dr. Carr, for your nice presentation. And now, without a break, we have to proceed to the next joint session 2, presented by